Good evening, everyone. Happy New Year. Welcome to our first forum of 2020, which hopefully you've already gathered is on traumatic brain injury. We're very fortunate to have Dr Ari Ercole with us this evening, who's a consultant in a neuro-intensive care at Addenbrooke's and also a pre-hospital consultant with East Anglian Air Ambulance. So I won't delay and I'll hand you over to Ari. Thank you.
Well, thank you for the invitation. So we're all live and more people watching, so remind me not to swear or anything like that. And I also tend to wander around, so if I go out of shot, just sort of point at me or something. It's a great pleasure to be invited to come and speak. That's a really nice audience, including some blasts from the past, which is nice, which I thought I put this picture in, actually. I don't know, there's some people there that, I think it's actually even before your time, I think, that but I've been doing some pre-hospital care for a little while now. And so I'm going to talk really about traumatic brain injury from a pre-hospital point of view. And I've sort of given a subtitle to this talk, Why I Wish I Was More Interesting. I'm fundamentally a very boring person. I'm going to admit that straight off. And what I'm hoping to do is make this subject extremely boring for you tonight. And I'm glad you're glad you've dragged yourself all the way here at 7:30. No, I'll justify that, I promise. Okay. Actually, so traumatic brain injury, it's a big part of my workload, and it's a big cause of morbidity and mortality around the world. And actually, we think we've got it bad. If you think about people with traumatic brain injury who go on, even if they do survive, potentially to have significant physical and neurological disability afterwards. So the social cost and sort of ethical and emotional cost of this disease is enormous. But actually, we have it reasonably easy because the real burden of this disease is borne by the low and middle income countries. And even that was really the tip of the iceberg because we've got very little data for a lot of traumatic brain injury, but it's extremely expensive, extremely important cause of morbidity and suffering for people around the world. And if you're interested in a little bit more about the epidemiology of traumatic brain injury, I'd really recommend this commissioned issue of the Lancet Neurology. Just find it if you search for the Lancet. It really goes into a lot of detail about why this is such an enormous public health problem. So it's quite a unique disease. The brain's pretty unique as well in terms of as organs go. If you look at a brain, it's fairly unremarkable looking thing. But actually, it's really unique in that, first of all, it's rigidly enclosed. There aren't any other organs that are inside a closed box. The other thing is that it takes a lot of energy. Well, unless you're a sort of daytime TV presenter, it takes that you use a lot of energy for thinking. Okay, so you use a lot of blood supply, a lot of oxygen, lots of metabolic substrate. And you don't have a lot of reserve of substrate in the brain either. So if you interrupt that blood supply or interrupt that oxygen supply, then the brain is going to suffer really quickly. It's going to run out really fast, and it's going to be and it's also quite reasonably fussy eater. So it's going to run out of fuel really fast, and it's going to die. Okay? So that makes the brain has its predisposition and exquisite sensitivity to secondary insults, to interruption of blood supply, interruption of oxygen supply to it. Okay? And the really crucial thing that I really want to think nothing about this, well, this is the second most important thing I'm going to tell you, is that even short periods really affect the outcome. Okay? So you become irreversibly dead very quickly. And it's not a matter of whether or not actually survival or not. We need neurons. Okay, so what we're trying to do, we're really in the game of trying to prevent damage to as many neurons as possible. So that at the end of the day, I mean, there's some primary injury that happens. Some brain is permanently damaged by the initial trauma. Can't do anything about that. That's all about wearing seatbelts and primary prevention, which is very important. But once traumatic brain injury has already happened, what we're really trying to do is to prevent that secondary injury, prevent those neurons from dying, and create a patient who is the best substrate for rehabilitation at the end of their acute phase. So that's what we're really in the game of. Now, for many, many years, I'm not going to show the photograph, probably not really appropriate for disorders, but for many, many years, traumatic brain injury was this sort of, well, you've banged your head and we'll sort of hope that you wake up and pop you in a corner kind of thing. And it has become an area of intensive care with an evidence base to it. It's become a subspecialty. Do we make any difference? Well, it's quite difficult to know, but it's quite a nice paper, sort of before and after paper, showing that actually not only by good intensive care management of traumatic brain injury, it's not just that we're creating survivors, because that's of course the worry, that we create survivors who are so terribly disabled that because survival is not a good thing necessarily at all costs. It depends on your viewpoint. But we're actually also creating survivors with good neurological outcomes as well. So we're actually improving things across the board. And it's quite Gucci. We do lots of stuff. This is a picture of exciting stuff going on. There's a ventilator at the end and there's all sorts of monitors, and there's someone from Papworth putting ECMO in at the moment. So we do some exciting stuff. But I'm not going to talk about the critical care management of traumatic brain injury, because I'm going to really focus on the stuff that's pertinent to the pre-hospital really early phase. If you're interested in all of it, and this does cover the critical care management as well. This is an article that we wrote a few years ago. It's an education article. It's quite, well, we think it's quite good in as much as it has a good evidence base in it. It's reasonably up to date, so feel free to go look that up. But a lot of what we do is this algorithm. A couple of critical NCCU nurses and hello NCCU nurses in the audience, and they'll be exquisitely familiar with this. We have a protocol-driven way of dealing with traumatic brain injury patients. And if I can find a little pointer. You sort of divide into these stages. We do increasingly dangerous stuff as things get more and more desperate. And we start with simple things, which is to kind of keep the patient oxygenated, right? Keep their saturation up. We keep them their ventilation normal. This is a cerebral perfusion pressure, so keep their blood pressure sort of normal. Keep reasonable hemoglobin in so they can get oxygen to their brain. I mean, all kind of simple stuff. Really control their glucose, keep their temperature sort of normal, at least not hot. So we do kind of simple stuff. And when that doesn't work, we do more dangerous stuff like involving drilling holes in heads and draining fluid and things out. And when that doesn't work, we do more dangerous stuff, such as cooling the patients or putting them into deep coma with barbiturates or actually decompressing and removing part of the skull. But really, this early bit, is the bit that's important from the pre-hospital phase, or elements of this. So I'm really going to kind of focus on it. And a lot of it's about this. So we have this idea, or at least we think a lot of it is about this, or people think a lot of it is about this. We have this idea that you have this cerebral perfusion pressure. So you've got a mean arterial pressure. This is the pressure that your heart is generating as you pump blood, right? And you've got a pressure in your head as well. As your brain swells, and I'll talk about why your brain swells in a moment, as your brain swells, the pressure starts to increase within your head as well. And that pressure in your head starts to oppose the pressure of the blood being pumped towards the brain. And eventually the pressure in the head is so large, then there isn't enough blood pressure to actually perfuse the brain. So we have this idea of a cerebral perfusion pressure, which is the difference between the mean arterial pressure, the blood pressure, and the intracranial pressure. And we kind of naively think, well, it's all very important. What we need to do is keep the mean arterial pressure up, keep the intracranial pressure down, reduce that swelling, and maintain cerebral perfusion pressure. But even this is a little bit sort of simplistic, because, in fact, does this really apply? Is this important? The question we have to ask ourselves, is this really important in the pre-hospital phase? And I'm going to make an argument to you that, in fact, not entirely, perhaps. The really crucial thing is we do need to maintain some kind of decent blood pressure. Okay, and the reason we need to maintain decent blood pressure is because normally the brain maintains its blood flow by autoregulatory mechanism. So as your blood pressure always goes up or goes down, depending whether you're excited running for a bus or just relaxing, what will happen is that your brain maintains an adequate cerebral blood flow irrespective of that blood pressure. Okay, it's autoregulation. But that can fail. That can fail after trauma. It fails sort of variably after trauma. It can fail after you've had some other brain injury if you've not got enough oxygen supply. It can fail in a whole variety of circumstances. So actually, the thing that these patients have is they're not able to autoregulate themselves. So it's really critical for us to try and maintain decent physiology in these patients because they can't do it themselves. Now you, in the audience, I hope not, but if you were to have a low blood pressure, you would compensate for that for quite some distance of time before you actually start to feel faint and become unconscious. But in the brain, that may not be possible. The brain may not be able to vasodilate and allow more blood for even quite modest reductions in blood pressure. So that's the important thing, blood pressure. We worry a lot about this intracranial pressure. Everyone's heard about intracranial pressure. What about the ICP? What about intracranial pressure? And we do worry about that justifiably in later on in these patients in intensive care. It is important. Raised intracranial pressure will kill you. We do some fairly extreme things, including monitoring their intracranial pressure. This is a triple bolt. This is a hole that's been drilled through the skull, and some sensors, including a pressure sensor, have been inserted into the brain parenchyma, into the frontal part of the brain, to measure the pressure. And by measuring that, we can control it and guide our therapies. And it's all very, very Gucci. This is what people think about in terms of neurointensive care. We've got to be, drilling holes in people's heads and measuring intracranial pressure. Question, of course, is, and of course that must be what's making people better, because I showed you the graph earlier that by doing neurointensive care, we're making people better. So aren't we awesome? This is so awesome, okay? Well, the reality is actually it doesn't work. This was a study that was done, or at least it's not that simple. This was a randomized control study. We thought we were pretty lucky actually, because we thought no one would ever, it's so obvious that you should measure intracranial pressure that it's not ethical to go and do a study, so we're safe, right? And no one will ever prove it's wrong. It turns out it sort of seems ethical in South America. It may not be ethical here, but it's ethical in South America. So they did it and actually showed that actually it isn't just the measurement of intracranial pressure. Now, Randy Chestnut, who did this, would be the first person to say that it's not saying we shouldn't be measuring intracranial pressure. There are uses for this. But what I'm trying to get at is it's not all the Gucci stuff that really is making the difference here. It's in fact something else. Now, coming back to the pre-hospital phase, what can we do to try and make the situation better? Well, here's a diagram from that Handbook of Clinical Neurology paper that I showed you earlier. It's a bit of a cartoon, but just to kind of sort of go through this, once you bang your head, you have a traumatic brain injury, it starts a whole variety, a cascade of different processes, okay? So then you've got various things, intracranial pressure, cerebral blood flow, and sort of this cartoon of different processes. And here we've got time after trauma. And so you bang your head and you cause some injury, there's some bleeding, some destruction of some cells, and that induces an inflammatory response. In the same way as if you hurt any other part of yourself, you will have an inflammatory response. And white blood cells get recruited to the area, and they recruit other white blood cells, and various genes get activated, and then various other genes get activated, and some of these genes may control vascular function, and then other genes may control vascular integrity, and then the vasculature might fall apart, and you have more bleeding into the brain. All of this is associated with swelling. That's a kind of cartoon of what happens, but the point is, it happens later. If you bang yourself, if you hurt yourself, if you sprain your wrists, you don't normally swell immediately. Yeah? It's something that happens over hours or days. And that's kind of what this diagram is trying to show here, that really the peak sort of swelling processes, the peak thing that's going to cause the pressure to go up, is really happening not necessarily immediately. Of course, all patients are different, but maybe in the first 24, 48 hours. And in fact, nurses that are here will I'm sure, well, tell me if you disagree, but actually things don't usually get really rocky really early on. They get rocky on day 2, day 3 with intracranial pressure. So the problems that we've got in the pre-hospital domain are a little bit different from the intensive care domain, which is a little bit disappointing because it sort of seems that actually all I'm saying is you just need to do the basic stuff really well, because I haven't really got anything else. I can't really pin why it is that we're doing so well with this. So it's sort of boring. Well, okay, maybe not. We do actually... Oh, it's gone blank. It was so boring, it actually bored the computer today. But actually, it turns out we know quite a lot about the biology of this. Okay, so the primary injury, the thing that the direct consequence of trauma, has these multiple consequences. Okay, it causes neurotransmitters, excitotoxicity, the inflammatory response I've already told you of, microglial activation, blood vessels become leaky and finally actually break down. So there's lots of biology going on here. So surely we should be able to find a drug. We must be able to find a cure for traumatic brain injury. That would be pretty cool if we could find a cure for traumatic brain injury. So we can start looking at all this, and that's exciting. And people have been doing this for a long time, and it works fantastically. Lots of these things cure rats who've had traumatic brain injury. Sadly, it's all kind of failed to translate to humans. And there's a whole catalogue of things that seem to be really biologically plausible, but didn't work when we tried it in humans. So that's what, again, incredibly disappointing. Sounds like it's quite boring. All we're going to be able to do is just make sure we're doing the basics really well. Well, that was up until quite recently. There was this study. This is the CRASH-3 study. So I'm going to talk quite a lot about this and really motivate the whole talk about it. So the CRASH-3 study was a study of tranexamic acid, specifically in traumatic brain injury patients. And they concluded that the tranexamic was safe for patients with CBI, and treatment within 3 hours of injury reduces head injury-related death. Patients should be treated as soon as possible after injury. And I'm going to talk about that because that sounds quite amazing, because that is, for the first time, apparently, a pharmacological intervention, not a cure, but it's a pharmacological intervention that would seem to make traumatic brain injury better or improve outcomes. But there is a little bit more to this, so I'm going to dwell a little bit on the study, and I'm going to talk about, in perhaps a bit more detail than you might be used to, about the study, because I think it's really important not to believe hype when it comes along. No matter how enthusiastically perhaps it's dressed up, it's always worth being a little bit cautious about conclusions and how far we push these things. Anyway, going back to traumatic brain injury, let's start by classifying it, because that would seem like a sensible thing. Perhaps we could divide our treatments into different groups. Well, we classically classify traumatic brain injury into mild, moderate and severe, and we do that on the basis of how conscious people are, and we traditionally measure how conscious people are using the Glasgow Coma Score, which I'm sure everyone in the audience would be familiar with, dividing the 3 domains, the eyes, the verbal response, and whether they can obey commands or not, to varying degrees. And we develop, so you have mild traumatic brain injuries, the piece with GCS with 13 to 15, moderates with 9 to 12, and then severe traumatic brain injuries, those who are in coma, who have a GCS less than 9, so 8 or below. Now, this is, of course, a completely nonsensical classification. This will be a little bit like saying, actually, I'm going to classify cancer into mild, moderate, and severe cancer. Now, if you say that to oncologists, they just look at you, because it's actually an extremely complex disease. Really, the way to classify it is using one of these. This is a CT scanner, and the main thing that is going to tell you how bad someone's traumatic brain injury is not just how unconscious they are, because there are people who after an accident are awake and walk around and then subsequently go on to die, and there are people who are very, very deeply unconscious, GCS3, so completely unresponsive, who subsequently go on to make really good recoveries. Okay, so that mild, moderate and severe thing doesn't really correlate terribly well with what really the kind of biology of the brain injury is going to be necessarily. But the thing that will tell you, and therefore the thing that is very urgently required in anyone in whom you suspect a significant traumatic brain injury, indeed the only thing that will tell you whether someone actually has a significant traumatic brain injury, whether someone who has been knocked out at the scene of some trauma and woken up again, perhaps a little bit confused, whether that is just going to get better or whether or not there's something that might end up bleeding and killing them, is this machine, okay, is a CT scanner. Okay? So there's a priority to get people in whom you suspect severe traumatic brain injury into a CT scanner so we can make a proper diagnosis, not just this nonsense of, well, they seem a bit sleepy. Okay? We really want to know what's going on inside. Because actually, it comes in all different shapes and sizes. So over on the left-hand side of the picture, you can see some contusions. Classic, actually, these sort of frontal contusions, they really frighten me. But what you see on CT scan is really white stuffed bone, slightly white stuffed blood. Right? So you've got little areas of bruises within the brain. Over in the middle, we've got something called a subdural. That's bleeding around the surface of the brain. Actually, these generally have the worst kind of prognosis in the acute setting. And then over on the right-hand side is an extradural. That's actually bleeding that's outside the brain. It's between the layers of the dura, which has been split and peeled off the skull. And that actually, this isn't even a neurosurgical problem. This is really an orthopedic problem. Okay, because if you just suck that out, then the brain shouldn't necessarily be damaged underneath it. But of course, if that bleeding continues over time, the brain will be squashed, the pressure will increase, and we'll run into trouble. And then there'll be patients who actually have relatively blameless-looking brains. This is a patient who, well, obviously died. I think you can probably tell that. But actually, the brain doesn't look too abnormal, but you do see some abnormalities. Okay, and this is a traumatic axonal injury where actually the brain tissue at a gross level, a macroscopic level, looks all right. But actually, what's happened is all the little connections that are in the brain, the thing that makes the brain work, it's the connectivity between the neurons that allow us to think. Those connections have been damaged. So, what do we learn about this? What can we tell from that kind of imaging? Well, what's relevant to us is the implications that has on terms of cerebral blood flow. So this is some pictures from one of my colleagues, John Cole's piece of work. Here on the left-hand side, you see a CT scan, and you'll recognise from the earlier CT, this is an extradural hematoma. So, and then in the middle, that's the injury. In the middle, we've got, this is a PET scan, positron emission tomography scan. We don't normally do these in clinical practice, a research scan. And what this is showing is blood flow. And actually, what you can see here, it's not very obvious, is this looks relatively blameless looking bit of brain, but not totally. Actually, we've got reductions in blood flow. Okay, and then if we go on to here, this is 6 months down the line, this is a magnetic resonance imaging scan. What this is showing is scarring and damaged tissues that's persisting, as we see that actually this area, which did have, it looked reasonably blameless, but in fact had reduced blood flow, has gone on to be injured and is scarred. So we're trying to stop those bits of brain. The bits that are completely mashed and damaged, sorry, there's nothing we can do. It's the other bits that are at risk that we're trying to get at. And again, the early phase, your phase, the pre-hospital phase, really, really, really matters. Because in every single study that's ever looked into this, I haven't got time to do it now, but I could do it now. I've got some data here, and I promise you it will come out exactly the same. Every single study shows that the two independent predictors of survival for traumatic brain injury, or reversible ones, age, unfortunately, makes you less likely to survive, but we can't do anything about that. Can't go back in time. But the ones that you can do something about are hypoxia, so low blood oxygen, and hypotension, low blood pressure. Those come out every single time in every single study as independent predictors of bad outcome, of death and bad outcome. So they are bad. So our job in the pre-hospital phase is not to do Gucci stuff with bolts and all sorts of that. No, that's later. Well, our job is to stop this happening, because this is what's going to kill people, and it'll kill them fast, pronto. Okay? And both of these things are common in seriously injured patients pre-hospital. Yeah? And they're both potentially preventable. Okay, so what is the early insult? What is the pathology that we're seeing? Well, actually, it's not raising. Some patients do have raised intracranial pressure, of course. You've got big blood clot, that's fine. But actually, really what we're seeing in many of these patients, most of these patients, is airway obstruction, hypoxia, hypotension, and generally speaking, hypoperfusion. So this is a recent paper, again, by one of my colleagues, John Coles, and so one of these guest authors. I don't really deserve to be on. I did the numbers for it, but I don't really deserve to be here. John did the bulk of this work. This is, again, a positron emission tomography study looking at traumatic brain injured patients. And I'll sort of draw you, essentially what he's able to do with PET scans is to look at cerebral blood flow. And this thing, oxygen extraction fraction. So as the brain gets starved of oxygen, it goes, oh, okay, I'm not getting enough blood supply. I need to extract more oxygen out because there's not enough coming in terms of total. Right, so I extract as much as I can. So you can actually see, when you see high oxygen extraction, that's worrying, because that's a bit of brain that's trying to get it's suffering, and it's trying to extract as much oxygen as it can from its impaired blood flow, okay, which is reduced on this one. So what John and his co-workers did here is they plotted across all these patients cerebral blood flow and oxygen extraction over time. And it's quite dirty data. This is a really difficult technique to do. But I want to show you this graph. That actually what happens is the oxygen extraction fraction is really high early on. And if we go over here to look at the cerebral blood flow, okay, we've got low cerebral blood flow. So the patients that we're seeing really early, in the first day or so, right, these are patients where the main pathology is that they've got reductions in cerebral blood flow. So you can imagine that actually if they're hypotensive on top, and these are resuscitated patients, they're hypotensive on top of that, they're really going to suffer. So we cannot allow these patients to have low blood pressures. If you don't believe that, it's very hard to do a randomised control, it's not ethical to do a randomised control study on this. But we can look at observational research. It's about 4,000 patients or so. Nice bit of observational work. And it's not like there's some kind of threshold either. Think, well, there'll be, as long as they've got a radial pulse, then there isn't this threshold. Okay, so if you look, as we reduce, this is a graph of death rate, crude death rate on this side, against lowest recorded pre-hospital blood pressure. It's a nice bit of work. It's quite hard to get all this kind of data. What you see here is an increasing death rate. The systolic's below about 110, 120, which is a bit hypotensive, but certainly, you're not going to lose your radial tilt down here. Okay? It doesn't look like there's some kind of point at which it's safe to be as long as you're above it. And you think, well, okay, this is crude death rate. People that are really badly injured for other things will have a lower blood pressure because they've bled or something. But if you correct for those things as best you can do with injury severity score, then you still that trend still exists. Okay, so low blood pressure is bad for you if you've got brain injury. So this is why I'm really boring, because actually the real treatment, most important treatment of traumatic brain injury in the pre-hospital early phase, okay, is just the CABCDEs. Okay, so the first thing is we don't want patients to be hypotensive, so they mustn't bleed to death. So we must stop them from bleeding to death with all the things that you will know about that stop people from bleeding to death, including. You have to understand that you will never bleed so much into your brain to become you will never get hypovolemic from bleeding into your brain, okay, unless you've got an extremely large head. This is just not going to happen. But you can get hypovolemic from an exsanguinating wound, but you can also be hypovolemic if you've broken this, lots of different things, okay, so for multifactorial reasons. And a lot of our major trauma patients have broken many, many things and have various reasons for being hypertensive. So we need to stop that. Okay? And if we can't stop it, we need to take them somewhere really urgently where it can be stopped with some steel and suture. I told you that airway obstruction is common, or impaired airway because of airway reflexes, because these patients often aspirate, all sorts of problems with these patients when they're unconscious. So we need to control that. And it doesn't really matter how you do it, and that might just be putting the patient on their side, it might be suctioning them out, it might be putting a Goodell airway in, it might be intubating them. The important thing is that these patients have to have an airway, right? Otherwise, even short periods without an airway is going to really prejudice them. Now, we're increasingly intubating patients, severe traumatic brain injury patients at the scene. The question, of course, then is, does that work? Well, we don't really know is the answer. That if you can find as many papers that say it improves your outcome as makes your outcome worse. It almost certainly depends on the way that it's done. It varies enormously out to Europe. This is an article we published quite recently looking at the probability of being intubated if pre-hospital, given you'd had a head injury. And you see it varies quite a lot throughout Europe. It's really hard to take any conclusions as to whether it's beneficial or not. The important thing really is if you're going to do it, you need to do it properly and not make the problem. Because the danger of anaesthetising people and intubating them is you might make them hypotensive, and then you've just made things worse. Then the patients need to breathe properly, and they need to breathe now at appropriate kinds of rates and depths. It's a little bit technical, but The thing that controls your carbon dioxide levels in your blood is how fast you breathe, how many litres a minute of air goes in and out of your lungs. That's your ventilation. And we potentially have control over that. If you've anaesthetised someone and put a tube into their mouth, well, it's the ventilator that's breathing for them, so we can completely control that. And the other thing that carbon dioxide is very important for is it's one of the main determinants of your cerebral blood flows and how dilated your cerebral blood vessels are. So if your carbon dioxide is really high and you've got a blood clot in your head, then your blood vessels will be really dilated. So actually there's more volume of stuff in your skull, and so your blood pressure and so your intracranial pressure will be higher. But I've already told you that, so that's the one thing we sometimes do when we're really when I'm really desperate with a patient whose intracranial pressure is completely out of control. Sometimes by just getting the carbon dioxide levels down, you can control that intracranial pressure. But it comes at a cost, because think about it, what's the reverse of that? If I ventilate someone too much, I get their carbon dioxide levels really low, then actually they're vasoconstricted. Well, excellent in terms of the amount of volume in the brain, but I told you that intracranial pressure usually isn't a problem in the early phase, and what I've just done is vasoconstricted everything. In other words, I've actually reduced the blood flow. If you don't believe that, this is another positron emission study from actually some years ago. Again, John Coles' work, a real expert in positron emission tomography in acute traumatic brain injury. Here you see on the left-hand side is a patient with a sort of normal, slightly higher carbon dioxide level. The red bits are the bits in which the oxygen extraction the blood flow is critical. Okay, so there's a few bits of critical blood flow. On the right, we've got a patient who, just trust me if you don't look at these kind of blood gases regularly, is relatively mildly hyperventilated, so ventilate a little bit too much, a little bit low carbon dioxide, and it's all gone red. Right. So actually controlling this kind of stuff, controlling breathing is really important, not just in terms of not getting oxygen out, but also in terms of their carbon dioxide levels. But not so much because of the intracranial pressure at this point. It's more about making sure that you've got decent blood flow. Hypotension, well, we have to maintain perfusion. Okay, so essentially what I usually try and do in these situations, I try to resuscitate to normotension. I don't really know what normotension is, but that's what I'm trying to achieve. Now, I hear what you'll say out there with you come to me with your permissive hypertension arguments. Well, fine. The point about permissive hypotension is not that we should be trying to aim for low blood pressures in people. It's that if someone's actively bleeding, it's futile. You cannot get their blood pressure up because they just bleed out again. And all you do is give them 8 litres of fluid that makes them edematous and so on, for no benefit at all. Right? In fact, you harm them from it, and you haven't actually improved their blood pressure because it's futile. Right? So those are the patients that you'll try and get their blood pressure up. You won't succeed. The only solution for them is to have whatever bleeding problem it is stopped in theatres or something dealt with surgically. Okay? But it is not the case that we are aiming for low blood pressure. If you can get the blood pressure back up to normal, that is undoubtedly going to be a better thing to do. Then other kinds of stuff, glycemic control, hypoglycemia. The very first patient that I intubated, anaesthetised pre-hospital on the helicopter, which is some years ago now, was a chap that crashed his car into a tree. And actually, it's very interesting because he had normal blood sugar he looked really sweaty and was half unconscious. He was trapped in the car for a little while. And the first blood sugar I did on him was actually quite normal. It's really unusual because most patients who've sustained significant trauma, will be hyperglycemic as a stress response from it. And in fact, what was actually quite really spooky about having a low normal blood glucose made me actually realise that in fact the reason that he crashed his car is it was because of hypoglycemia. He then went on to become hypoglycemic. He was diabetic. So most of these polytrauma patients become hyperglycemic, have high blood sugars, and if they don't, think it's something a bit weird. This is harmful as well, okay? But both high and low blood sugars after any kind of brain injury are really harmful for you. So we in hospital try to control that quite carefully, but we don't really strive so carefully. This is less important. So you really don't want people to be hypoglycemic. Think about that. But you're not going to start giving people insulin pre-hospital, try and bring their blood sugars down. That's just not worth it. It usually takes, again, a few hours before this stress response really kicks in. The next thing in terms of disability is what do you do if someone really has got raised intracranial pressure? And the signs of someone, I told you that mostly in the pre-hospital phase this isn't the problem, but sometimes you do, right? You sometimes have a big blood clot, big extradural, big subdural, squashing the brain. And the problem with when the brain gets squashed is not only is it starved of oxygen, but it doesn't have anywhere to go. Or better say, only has one place that it can go, which is the hole at the bottom of the skull. And it competing for real estate in the hole at the bottom of the skull is the brain stem, which has a whole variety of crucial structures. So what happens is the brain just gets squeezed into that space with the brain stem, and ultimately, if it's really bad, the brain stem will be damaged or even die, and the patient then is dead. And what are we going to see? Well, early signs of that. Clearly, these patients are going to become unconscious, but that's not a particularly specific sign of herniation. But we'll also may see eye signs, so one or two pupils dilating. That's also associated with poor outcome. When it's really bad, sometimes we see high blood pressure and this kind of Cushing response that you read about in some of the books, that you see bradycardia, slow heart rate, high blood pressure. I have to say, things are quite late by the time that happens. Usually sort of a pupil going or something is earlier. What are you going to do pre-hospital? We can't start taking bits of skull off. We can't, we're not going to know what the blood pressure, what the intracranial pressure is. Well, under those situations, it's reasonable to use osmotherapy. Osmotherapy are kinds of drugs which have a very high concentration to them, have more osmolality than the blood does, and essentially suck water, fluid, out of the brain cells into the circulating volume instead. And the two drugs that are commonly used, most commonly, is mannitol, which is a kind of sort of sugary stuff that Heston Blumenthal sometimes cooks with, or hypertonic saline, which is sort of salty water, really. And you'll see either of those, and the kind of indications or situations where you think, actually, there's impending herniation, really can't worry about this. These are not things to give routinely. There's a randomized controlled trial, actually, that shows that giving mannitol to everybody doesn't help. Okay, there's things to do using a rescue situation. On top of that, one thing I'm going to say, being slightly controversial, mannitol is the satanic urine of Beelzebub, it really is, except it's still mostly used. The reason I absolutely despise it as a drug, and I've got a little paper out quite recently that even suggests that there is a harm signal in the data. The reason I despise it, it causes a diuresis, it causes you to pass urine, and it can cause you to pass a lot of urine. And in a situation where a patient has got their brain is swelling and their intracranial pressure is potentially really high and are not getting enough blood supply to the brain, the last thing I need is to then also render the patient hypovolemic because they've peed out most of their circulating volume. And I have seen that happen. So I actually really despise that. Hypertonic saline, on the other hand, is the reverse. It actually draws water into your circulating volume. So given the choice, I go for the latter. Watch this space. There's a study being planned at the moment to look at this in prospective patients. And then finally, temperature. Trauma patients are usually slightly hypothermic. What we know in patients with any kind of acute brain syndrome is that high temperatures are bad for you. And particularly rapidly rewarming people are bad for you, is bad for them. And we know that from cardiopulmonary bypass work as much as anything else. And that's kind of actually may account for one of the reasons why a lot of the translational drugs that we're interested in rats and animal models haven't translated into human benefit. Because you can imagine, it sort of highlights it. So you can imagine you've got a patient who, if you get an animal model, then you cause some sort of model of a brain injury to the animal, and then you do the therapy to them. Well, actually, our patients, they crash their car or whatever it is that's happened that's caused them to have a traumatic brain injury. They're trapped there for a little while. They get cold. We take them out. We warm them up. Then they cool down again. Then we warm them up. We take them to the scanner. All sorts of things happening. It's much, much more complicated. And I think that and the same sort of things happen for in other domains as well. Probably go some way to explain why it is that some of these the translational failure of some of these otherwise plausible drugs. So we want to avoid people being hyperthermic, but that's probably not going to be a big problem in the pre-hospital arena. Hypothermia is not a good thing either, but actually, to be honest, it's quite hard to really warm a hypothermic patient up pre-hospital. Really difficult to do. It takes hours once they've actually got hypothermic. So again, really, it's about getting them out of the hypothermia-inducing situation as quickly as absolutely possible and getting them somewhere where that will be arrested, rather than hoping you can rewarm them, because it's not good for them and it doesn't work very well. So, in the last little bit, I want to talk about CRASH 3, which is this study, and maybe it is a good study, actually, so I don't want to be negative about it particularly, but I just want to sort of draw your attention to a few things. I'll tell you where this came from. So CRASH 3 was planned some years ago, randomised controlled trial. I first heard about the results. I was actually out in Vancouver at a Neurocritical Care Society meeting. I was out there sort of teaching. I do compute. See, I'm a really boring person. I do computing and data-driven stuff normally. That's really why I was there. So I thought I'd do is I start first to really make your evening by doing a little tutorial on statistics. See how enthusiastic everyone was there. Everyone literally came to light when I said that, everyone's faces. Or else I will if I can find my mouse. Get rid of that. Have this. There we are. So there's some statistics for you. What I thought I'd do, I've just made some random... Can everyone see that all right? Yeah, you don't know, the details don't really matter. Maybe we can make it a little bit bigger. How does it make it bigger? There we go. Right. So here's a simulation. It's written in a computer language called R. What I'm going to do here is I'm going to do... So in a study, right, you do something to people or you give them a placebo, right? So it's either thing or placebo, yeah? And then you see whether something happens or something else happens, right? So whether they die or survive. And clearly, it's not like everybody who gets the drug is going to survive and everyone who gets the placebo is going to die. It's going to be more mixed up than that, isn't it, right? So you can imagine I could represent this as a 2-by-2 table. So on one side, it'd be the people that got the drug or didn't get the drug, and then whether they survived or died. So the 4 combinations: got the drug, survived; got the drug, didn't survive; got the placebo, survived; got the placebo, died. Yeah, happy? And there'll be some numbers, and when you add them all up, that'll be the total number of patients we've got. So I'm just going to make some random numbers up. So you trust me, this bit of code just makes a random set of 2-by-2 numbers, okay? So if I just run that, there we go. It's made, and these are just random numbers it's made up, right? So it worked out that 5 people in the treatment group died, 15 people survived, 4 people in the placebo group, and we've got 20 patients in each group. Okay, that's how I've set this thing up. Now, of course, so what does it look like? It looks like, so slightly more people died in the treatment group than the placebo, but only a little bit. Could that have been by chance? Because if I was to run this again, I'd get a different answer. So well, it turns out you can do some statistics on it. You can work out what the probability of seeing a difference like that if it just happened by chance, right? So if I do that, I've got and there's a test for that. It's called a chi-squared test. If I do that, actually, the probability of seeing that by chance is 1, right? So it's really, really high. So what we're essentially saying here is that difference, right? That's not nearly extreme enough to have been of anything other than chance, okay? Really unlikely. Now, of course, if I did this thing again, if I took more random, this has nothing to do with the trial, I'm just taking random numbers here, yeah, and I don't know what these numbers work out. That's the problem with making stuff up. You never quite know what's going to happen. I'm going to do this 100 times, right? So I'm going to do 100 2-by-2 tables and do chi-squared tests for each of them, right? And they're just random numbers, okay? Random. So there isn't a real placebo treatment. It's just random numbers that I'm just drawing, and then we're going to do the p-values for all of them. And so there's like quite a few of them. It would be quite tedious to work it out. Now, what we do in trials is we pick a threshold. So, well, actually, if the probability of seeing that result, like this result, 5, 15, 4, 6, whatever it is that we get, if the probability of seeing that or a more extreme result is less by accident, if it was just random numbers, is really small, then we go, well, probably that wasn't something random. So we're looking for a really low chance that this could have happened by random. Doesn't mean it wasn't random, but make that unlikely. And traditionally, like mostly we tend to go at 5%. So we tend to say, well, if like less than 5% chance of something happening by random, then maybe that result probably wasn't a fluke. Okay, so we're looking for numbers less than 5%, so probability is less than 0.05. Now think about that. That's still not that unlikely. That means I'll still get a fluke, 1 in 20. Yeah, I'd still see a significant result 1 in 20 times, even though there was nothing to see there. All right. But let's have a look at these. So we've got 0.49, so that's 50%, so 1, 28%, 29%, 50%, 1, 0.04, so that's 4%. So that, had that been a trial, that would have been a positive result, but it's just a random number. What are we, 1, 1.3, 1.1, 1.4, 8.3. I hope there's going to be something. You never know what's going to happen here because it's real live television. Ladies and gentlemen, there was something. 0.3, 0.31, 0.08, 0.03, so that's 3%. So that one, if we'd done that one, that random set of random numbers, we'd be reporting that this drug worked. But it's just a random number. Go down. So it doesn't happen very often in the way that I've set this one up. But there were at least 2 occasions here that just random numbers generated a drug result. It looks like we've got a real result. That's only because I've run it about 100 times. So if I keep repeating stuff, at some point I'm going to get a plausible result, even with just random numbers. Hold that thought. Just hold that thought. Where is my brown thingy gone? You didn't think that you were going to get a statistics lecture this evening either, did you? But it's good for the soul Anyway, hold that thought. So this is tranexamic acid. It's a lysine analogue. It's been used for a variety of things, including mostly heavy menstruation. It's a very, very cheap drug. It's pretty safe. And people got interested in it in trauma because of something that we started to realise, that actually patients who have major trauma have this thing called acute coagulopathy of trauma shock. So, we talk about coagulopathy of being cold or giving fluids, or so, which, a lot of which is probably nonsense, actually. But actually, one crucial reason that people become coagulopathic after trauma, in other words, their blood doesn't clot properly, is because of this mechanism. It has nothing to do with any of the other stuff, but is a direct result of the fact the patient was shocked. So if the blood pressure was low, it activates the endothelium, which sets off an inflammatory cascade, which for a reason I'm not going to go into because it's rather complicated, means that these patients end up unable to clot their blood. Another reason that permissive hypertension is not good for you. It's just not as bad for you than futilely giving them fluids when it isn't going to make them better. And one of the things we see is this thing. This is called a TEG machine, and this is a way of looking at blood clotting. And what it does is it has this sort of pin or in a cup or the other way around. There's different designs. And they sort of spin one or the other. And as the blood clots between the two, as one spins, it starts to carry the other bit with it, okay, because it solidifies. So you see the torque over time here on this graph. Initially there's no torque, but then as it solidifies, you start to see that it starts to pull the cup or the pin with it. And so it forms this nice clot. Sometimes, though, this happens. So here we've got a situation where a clot forms, but then breaks down. Now, we've got fibrinolytic mechanisms. If we weren't able to break down clots that we form all the time, we'd just be a big clot, right, at the end of our lives, because you're always subject to little bits of trauma. So we have got a mechanism for breaking down blood clot, but it's not normally activated this fast. So this is hyperfibrinolysis, which is something we see after trauma. And what tranexamic acid is an antifibrinolytic. It prevents that. If you believe that, you believe anything. But no, it definitely does prevent that. It may do a whole load of other things as well, which I'll come to. And we think it's quite a good thing to do in trauma patients. So now, set the traumatic brain injury patients aside for one moment. In trauma patients, there's a big study called CRASH 2, back in 2010, which gave a particular regime, a gram of tranexamic acid, then another gram over 8 hours. And they found a reduction in all-cause mortality, a relative risk of mortality of 0.91. And there's some other things that emerged from it that in a subgroup analysis, early was better than late. In fact, if you gave it after 3 hours, that seemed to be harmful. So this was fairly convincing. And actually, our trauma patients, the inclusion criteria was anyone that people thought might be bleeding lots, and it was fairly pragmatic. So it's fairly convincing. The nice thing about this study, all right, is it was 20,000 patients. I mean, this is a mind-blowing study to put together. It was done in low and middle-income countries, it's a pretty big relative risk reduction. If you work out with the mortality of these patients about 5%, we've got an absolute risk reduction about 0.8. Number needed to treat of 125, which doesn't sound brilliant. That's to say, if we were to give 125 people tranexamic acid, we'd save one life. But this stuff is cheap as chips. It really is. And it seems it was reasonably safe. They didn't show, you might think, well, if it makes you clot more, maybe you get DVTs and PEs and these, but it doesn't seem really to be the case, as long as you give it early. And actually, if you looked at the patients who died from bleeding specifically, actually now the number needed to treat is 42, so it's even better. Right? So it does seem to be quite good stuff. And if you don't believe this study, right, actually this is CRASH 2. There were other smaller studies which had the smaller and therefore the baseline risk was different, but actually also showed quite convincing results. The only one that didn't was this one from Miami, which actually showed that it increased mortality. But when you look at this study, look at this is a level 1 trauma centre. Look at their baseline mortality. I wouldn't want to be treated there. Just saying. Miami's a nice place and everything, but and there's this timing thing as well that you do need to give it within 3 hours, and I will return to that. So where do brains come into this? Why would we think? I told you don't bleed to death from your brain. Well, actually, traumatic brain injury is associated with coagulopathy, okay? For reasons that are not brilliantly understood, but we do see hyperfibrinolytic states after traumatic brain injury, isolated traumatic brain injury. And if you have lots of fibrinolysis, remember I showed you those big contusions in the CT scan right at the beginning. If you've got high fibrinolysis, they will tend to expand. They will blossom over time. People with big frontal contusions, people that know me on the ward, I'm scared stiff of patients with big frontal contusions. They often get worse over days. And it gets more worse faster if you have hyperfibrinolysis or fibrinolysis. So stopping that might be a good thing to do. On top of that, there was, in the original CRASH 2 study, and it's not a primary thing that they set out to do, but there was a pre-specified group, a sub-study nested within that study, looking at traumatic brain injury patients. It's small, of course, because it's a sub-study within a big study, but that did seem to suggest, it's not significant, but it did seem to suggest that actually this was a good thing to do in traumatic brain injury patients, which motivates the idea of doing a study specifically in that traumatic brain injury group, which is what they did. This is the trial paper, what they planned. And just to go through it, this is a double-blind, so nobody, the investigators and the people treating and the patients didn't know whether they were getting placebo or drug. Ran over quite a few years. They recruited, well, on paper, 12,700 patients, which was an awful lot. Actually, it's a bit less. I'll come back to why in a moment. This is like across 175 hospitals, 29 countries in high, middle and low income countries. I mean, I'm going to be a little bit critical of the result, but goodness, this is a fantastic, I mean, it's really hard to pull this kind of thing off. I think the logistics of doing this. Now, this is where it gets interesting from our point of view pre-hospital. The inclusion criteria, who were they looking at? So these were patients who had Glasgow Coma score, who either had a Glasgow Coma score less than or equal to 12, right, so it's the moderates and severes, come back to that in a second, or had a CT abnormality. So in the patients with the 14 and 15s, right, they would not have been included if they didn't, as well as having had a GCS 14-15, they had a CT abnormality. Just bear that in mind for a moment, because that's important for us as a pre-hospital community. What did they do? They did the same thing as in CRASH 2, so a gram of tranexamic acid plus an 8-hour infusion. And what was their primary outcome? So this is important. So when you do a study, you work out how many patients am I going to need to answer my question. And if you're going to do that, you need to say what your question is. So their question was this. Their question is, does tranexamic acid, giving it early, reduce head injury-related death in the first 28 days? Head injury-related death in the first 28 days. That is their question. That's what they set out to check. If you start asking more questions of the data, then remember what happened when I just took lots of random numbers? At some point, about 1 in 20 on average, you're going to get a fluke positive result, just because like sometimes you get fluke positive results. Okay? Just bear that in mind. So you set up, so you can't keep asking lots, you can't just go and get some data and keep mine it to death. You ask a question. Everything else, you have to take with a certain pinch of salt. You know? So these are the secondary outcomes. So they also looked, completely right to do, but so to be careful about how we interpret it. Early, so within the first day, head injury-related deaths, all-cause mortality, disability, vascular events, and others they're getting DVTs because you're a pro-clotting agent. Seizures, we know that tranexamic acid in cardiac surgery at really high doses causes seizures. It directly binds to the GABA-A receptors. Whether they spend less or more time in intensive care or need neurosurgery or not. Now, when you set out the trial, you work out how many patients are going to need to show an effect in that primary question that you have asked, because the others are all secondary. And they worked out, if they were to get about 10,000 patients, would give them a 90% chance of finding an effect if it was really there, if there actually was an effect. Okay? So they worked that out using some statistics. Initially, they recruited anyone within 8 hours of injury, but that subsequently refined that to 3 hours because the concerns that actually giving it after 3 hours might be a bad thing to do. And they changed their analysis. Now, this is not ideal for a study, but, you know, crikey, this is really difficult. So you can't really hold this against them. But as a result of that, they worked out they were going to need 13,000 patients. So that's what they did. They cracked on, recruited these patients. Don't need to worry about some of this stuff. But I will say it's really well done, right? They're missing outcome data on 0.8%. They're just really complete. I mean, awesome trial. Protocol violations where the wrong thing happened. Really small. Really, really good. Nicely matched. Very, very well conducted study. Okay. So what they ended up with, because of this changing the 8-hour thing, is actually they ended up with 4,000 patients rather that they actually use in the on each arm roughly, because the others were recruited later. So this is the mortality. People die early mostly but carry on dying over the next days. So here we are. What's the answer? Because this is the magic new bullet. This is the first time that a therapeutic agent has been cured traumatic brain injury, or at least seemed to help traumatic brain injury. Well, in the primary outcome, if you do the 2x2 table, the relative risk of death is 0.94. So it seems that you're slightly less likely to die if you have tranexamic acid, but actually it's not statistically significant. Right? That p-value, that probability that this was a fluke, is not less than 5%. So this is, strictly speaking, a negative study. So, yeah, this is not proven. It has not disproven the fact that it doesn't work. It hasn't proven that it works. Now, what the study then went on to do, which is the thing I slightly rudely put on the side of a bus, is they did a pre-specified sensitivity analysis. So they then excluded the severe traumatic, the really sick ones, on the basis they justified that these are the patients who are really likely to die whatever you do. Okay? And so we're just interested, so they're going to just like squash out any effect we're going to see. So we'll just look at the ones that we might have an effect of. And in this group of patients, so in the milds and in the milds with CT abnormalities and in the moderates, yeah, what they found was a reduction in the risk of death of a relative risk of death of 0.89, and this, okay, and that was not significant. Okay, just. You start pooling things together, though, with other studies, and there are some other studies that looked at this and aren't as good and aren't quite as big, then you do start to see a significant result, right? So it does look like, and the other thing is that all the studies seem to show the same thing, that it's like even the nested study within CRASH 2, these two studies, and they all show that it seems to be better. It's just that it's not a big enough effect to be sure about it. So it does, it's quite interesting, but it's only it just touches significance at best. And it touches significance when you start stratifying things by severity. And that's a little bit worrying, because remember what I said, the thing they set out to ask, the question they set out to ask was in everybody. That's what they worked their study out for. That's their primary outcome. When you start reanalyzing stuff, eventually you will get a positive result by chance if you do it enough times. It's just the way things work. I'll skip over that. Quite interestingly, though, they did also look at other causes of death. So this is important. As to whether or not this is safe, because if we did see more people dying in the tranexamic acid group, or more people getting complications, then that would be a bad thing, right? And actually, I won't go into this, but they didn't, because it looks like it wasn't causing any other kinds of harm. But the only thing I will say is that some of these things are a bit difficult to define, right? It's not totally clear endpoints on some of these things, so you can be absolutely sure of harm, no harm. Well, no, but it does look like it's grossly not harmful anyway. Okay. Disability, is it that these patients are surviving better? Well, doesn't seem to be. Are they getting more PEs? That's what really people are worrying about, because it makes your blood clot. Well, it doesn't seem to cause that either, and it doesn't seem to cause seizures. So it looks like it is probably reasonably safe. Okay. The other thing is that, what about this early sort of death business? So we talked about the situation in CRASH 2 that we had to give this stuff early, otherwise it actually was associated with mortality. Well, that again seems to be really interesting. This seems to be the case in CRASH 3 as well, that if you give it late, the later you leave this stuff, right, then then actually your risk ratio seems to get worse. So never mind about whether it's significant or not, there's a trend to it getting worse. So again, it replicates this idea that if you're going to do it, you need to give it really early. Okay. Yeah. So I'm just going to finish off then. CRASH 3. Really nice, because it is the first time that people have gone out to look for, and even got close to showing something was neuroprotective in traumatic brain injury, because nothing else has really worked. This is a really well conducted study, and it's done, pragmatically speaking, and under really difficult set of circumstances, but it has got some problems on it with it. And I think for us as pre-hospital practitioners, actually one really big problem is the inclusion criteria. So we cannot, the only patients that we can know would be included in this study are the moderate traumatic brain injury patients. The milds would not be eligible for anything until they had a CT scan, so still need to go to hospital, and so do the moderates. So there's a question of whether or not it can really change pre-hospital management. I think it is important to say that this is a negative study. I think it's a really interesting study. I'd be quite surprised if there wasn't something interesting about tranexamic acid. There's so much kind of evidence from other sources that it seems to have beneficial effects. But this is a negative study at the end of the day. It did not prove that tranexamic acid, did not prove its primary endpoint. But it is consistent, it's an interesting signal, something interesting to look at. Unfortunately, we probably won't see a better study, because this is really expensive stuff to do. So we need to work out what we're going to do on the basis of this. The other thing is, so we see the significant effect on mild, moderate traumatic brain injury, but it was not the primary endpoint. This is a reanalysis of the data, sort of recycling, if you like, of the data, even though it was pre-specified. So that's a slight problem, a little bit of a concern. The other thing that's a little bit tricky, I think, for me and I think some of my colleagues is, what's the mechanism? I mean, if we think it's something to do with bleeding, and maybe it isn't, because actually tranexamic acid is a really dirty drug. It just binds to lysine, which is a thing that you see on proteins, or an amino acid, and it binds to lysine anywhere, right? And it probably stabilises endothelial glycocaine. Well, it does stabilise endothelial glycocaine. It does lots of different things, right? Not just antifibrinolytic. But the mechanism is a bit weird. These are patients who probably don't have big blood clots in their head. So why would stopping them having a slightly bigger tiny blood clot stop them from dying? It seems a bit odd. That mechanism just doesn't quite sit straight. It does, however, seem to be safe, but there's there are really strict criteria for PEs and DVTs. There are some other analyses pending, particularly looking at whether or not looking at the imaging, so whether or not the tranexamic acid actually is associated with contusions getting bigger or smaller. That I think is going to be very interesting to look at. But at the moment, I think if you're going to be a trialist, a sort of trials fascist, then you have to live and die by it, and you have to sort of say, well, this was actually a negative study. So in conclusion, then, I told you this is where I'm going to prove that I'm a phenomenally boring person, I'm afraid. Basically, do the basics well. Okay. The really important things that we definitely know, and this is not like the p-value is much smaller, right? The things we know and make sense that cause bad outcomes are hypoxia and hypotension. So those are the things that we really need to fix. And you need to do whatever it takes to fix those. That's to stop them bleeding, get them to hospital extremely quickly if you can't stop them bleeding, or if you can't resuscitate them. Most of all, the most important thing out of all of this, which I think is really probably where a lot of the benefits of introducing neurocritical cares and having a subspecialty and so on, subspecialty, so on, come from, is it's really important not to bugger things up. Okay, so it's about doing the right thing every time for every single patient, doing the simple stuff really, really well, consistently well. Okay? And so I'm afraid I did warn you that I was boring, but most importantly, just try and keep calm and maintain the patient's cerebral perfusion and your own as well. That's all I've got to say. Thank you.
Do you have any questions in the audience? So there's a question online, if you don't mind.
Yeah, of course.
So it's around target blood pressure and permissive hypertension and the use of whether a patient's cerebrating, they're talking, if that's a useful tool. And would you mind answering that maybe in the context of an isolated head injury and then maybe in a polytrauma patient?
Yeah. So I mean, we're in it's a very good question, and it does kind of relate to what I do. I should just say that I can't guarantee the fact that someone seems to be talking completely guarantees there aren't little ischemic areas of the brain. Having said that, it is clearly reassuring. In a patient that is hypotensive and not cerebrating so well, it makes sense, at least to me, and particularly I'm talking about the isolated brain injury, it makes it simpler. It makes sense to me to try and resuscitate and make them not hypotensive, not hypoxic, and then reassess them. And then what you're left with, presumably, is whatever the nature of the brain injury is. And this sort of goes back a little bit to this idea. When a lot of these studies were done and Glasgow Coma Score was sort of invented, we had this idea of a best resuscitated GCS, which is the GCS you've got when you've corrected the hypoxia, corrected the hypertension, that's what you've got. Now, of course, the reality is that often life isn't quite so simple, and we correct everything all at once, and also that patients are not always isolated traumatic brain injury patients. So, in fact, in the sort of polytrauma patient, plus you've got someone flailing around as well, which is making management very difficult, and even measuring blood pressure very difficult. So these patients often do end up just getting intubated really severely, intubated very early. In which case, really, I think you have to give them the benefit of the doubt and really try and keep their blood pressure up. So resuscitate to normotension. Which doesn't mean really, really high, but equally bearing in mind if it's an elderly person. And the demographics of traumatic brain injury is shifting in all high-income countries, as this is all around the world. When I first started looking after these patients, it was predominantly, I characterised as 18 to 35-year-old males who've probably been doing something silly with the car or alcohol. And actually now we're moving on to the sort of 64-year-old plus females, just because that's predominant demographic in that age group, who've fallen downstairs with comorbidities. And these patients probably have very different blood pressure and targets and so on. And we just don't know because all our results have come from the younger group. But in terms of the permissive hypotension, though, whatever that normal blood pressure is, whatever you choose to think that might be, the big, I think, mistake of permissive hypotension that people have thought is that it's come along the fact that there is good evidence to suggest that if you try and resuscitate people, they do worse than patients that you just leave permissively hypotensive. But there's a misunderstanding there to think that actually that means that permissive hypotension was the good thing. It isn't that. Permissive hypotension is shock. Shock is also associated with bad outcomes. It's bad. The point really is in patients who are actively hemorrhaging, it is impossible. It's not that it's not desirable. It is desirable to get their blood pressure up, but it's impossible to actually do it. And that all you do is give them cause lots of tissue edema by giving lots of fluids. And that's why permissive hypertension is less bad in that group of patients. But in my experience, you have these patients, and you don't know whether they're actively hemorrhaging. Yeah, and they have hemorrhage, but now you've got a traction splint on, you've got a tourniquet, or whatever it is that you've done with these people. The only way you would know if they're still bleeding is to try and resuscitate them. Now, if they then don't resuscitate, well, then they're clearly still bleeding. And there is nothing that you're going to be able to do other than get them very rapidly to somebody that can do something. And that's really the truth, I think, of the permissive hypotension. And there's a little bit of stuff about vasopressors and permissive hypotension in brain injury. There's a lot of rat work that it's quite hard to extrapolate that, I think, into real meaningful clinical outcomes in humans, in my opinion, anyway. Any others? Otherwise, I'll do some more statistics and then the questions.
I've actually got a personal one that comes up a lot in my job.
We'll talk about it later. Or is that...
No. I'm happy to share. Okay. Given your experience of seeing these patients from roadside to recovery and probably the full degree of injury, Ercole quite clearly states that one of the signs unequivocally associated with death is massive cranial and cerebral destruction. And this comes up quite a bit when we're making decisions to resuscitate patients or not. And I just wondered your opinion on, firstly, that statement, and then secondly, any tips on how to recognise those patients that are perhaps futile.
Yeah, okay. So I think the massive cranial destruction is very reasonable. I think that's never going to be associated with an acceptable outcome and is going to most likely be associated with death. In terms of the other groups, so we've changed quite a lot. So I remember, even a few years ago, the neurosurgeons, because a lot of our evidence base was really kind of ended at the age of 65, people saying, well, they're over 65 and they probably do really badly. And these patients probably wouldn't get admitted because they just all do really badly. We have quite a lot of over 65-year-olds now. They do, well, some people do badly because not lots of people do badly full stop, but some do incredibly well, right? So that hard rule turned out to be wrong. If you fix and dilate both your pupils, that's pretty bad. That is associated with a really bad outcome. But if you put that into prognostic calculators and work out what's the chances of being dead as a result of that fixing dilating pupils, well, it's not 100%, it's like 80%. I mean, it depends on the age and all other bits and pieces going with it. And I was actually, funny, I was sort of talking about this to someone just the other day, and the longer and longer I do this, the less and less keen I am to want to prognosticate about things. And sometimes there's a really clear steer that disability is going to, the best case, is going to be really overwhelmingly likely. And sometimes there's really clear steer, not from the patient, but from the patient having spoken before about what they would and would not tolerate. And then those are decisions that are relatively easy about what you should and shouldn't do. But generally speaking, I think in most cases it's best to give people the benefit of the doubt let the dust settle, see how things evolve over the days that I showed you in that cartoon for the, crudely speaking, for the biology to sort of determine itself. And just be very, very cautious of self-fulfilling prophecies, because just now and then these patients do surprise you, and people you just thought, this has got to be hopeless because we've been hypothermic in a barbiturate coma for 2 weeks, come back and give you a hug, in the unit later. So just careful not to make self-fulfilling prophecies nowadays, I think.
Sorry, guys, there's 3 more on here that are quite good questions, actually. I'll try and rattle through them. So, hypertensive patients, anything sort of thought around managing hypertension pre-hospitally and maybe medically?
Good, good. That's a really good one. Don't touch it. The reality is that in traumatic brain injury and stroke, and that particularly kind of hemorrhagic types of stroke, the brain desperately tries when it's in desperate circumstances, not getting perfused, not getting its blood supply, its oxygen metabolic substrate. It will desperately try to do anything it can to keep the blood pressure up and keep the perfusion up. Okay, and so some of these patients may be patients where actually maybe even the brain stem is being squashed or being compromised. And when the brain stem is squashed, there's a huge catecholamine storm, this huge storm of neurotransmitters of adrenaline and noradrenaline that leaks out as well, pushing the blood pressure up. There's a reason why that blood pressure is really high. And there's a huge temptation. You see it and go, oh, crikey, 200, that's not good. And it isn't good, but actually dropping it at a point at which things are really potentially critical, it's very, very dangerous. And actually, just a few months, maybe 6 months ago on the unit, there was a patient that just looked like they weren't sedated properly because the blood pressure was really, really high. I just wandered over there and just, because it just acutely happened, I was just walking past, just looked at the pupils and the pupils are just dilated. And think, this is not poor sedation, this is not patient waking up biting on the tube, this is someone imminently about to cone, their brain stem gets squashed and die. Very careful about reducing that. I wouldn't try and reduce it. And it's quite dangerous when you anaesthetise these people as well. You really don't want to have this kind of alpine anaesthesia where the blood pressure is dumped to nothing because the brain may really need it. Good question.
Okay, second one. Crash 3 was predominantly recruited from UK and Pakistan. So are these EMS systems similar enough to give TXA its fair trial?
That's a good question. And I think that similar criticisms were comparable criticisms were aimed at Crash 2, levelled at Crash 2 as well. And the way I'd argue them in Crash 2 was, yes, but it's pragmatic, and B, it's pragmatic, B, you're never going to do any better because it's the only way to get the kinds of numbers to stand any chance of doing anything. And C, actually, there's other evidence out there as well. So if you get consistent results from other studies, that's reasonably reassuring. I agree, ideally one would recruit from, in some ways ideally one would recruit from a really narrow population that you can be absolutely sure about things. And that would be the sort of trialist method of choice. But there are 2 problems with that. One is a pragmatic problem that you'll never be able to do that. You'll never get the numbers just in one place. It'll take years and years and years and years and years and years, in which case then the EMS systems will probably have changed over that time as well. So you'll have the same sort of problem. And then the second problem with it is that actually when you increasingly narrow your population study group so much and so specify it, then someone like me, sort of smart ass, comes and says, yeah, but it's not generalizable to other populations, so we still don't know. So I think pragmatically they did something that was really smart and really sensible and executed it really well. I don't think we're probably going to see a much better study than that, unfortunately. So I think we have to decide what we're going to do with what we've got.
Thank you. Elderly patients,
yes.
Commonly chronically hypertensive,
yes.
Target blood pressures with those patients?
So we don't know, and it's another very good question. We should know, but we don't, because all our studies were done on the younger people that we thought were survivable before we kind of woke up. Probably higher. So like all organs, the brain will auto-regulate at a higher group of range of blood pressures. If I take things down to the other extreme, so what do we do in children? So there we do have some evidence, we have actually good evidence that these children will tolerate, in fact should be running at lower blood pressures than adults do. So it's not entirely unreasonable to extrapolate that up in patients that are chronically hypertensive. They will need a higher blood pressure than those that are hypotensive, yeah. But how much higher, we don't know.
Final one.
Yes.
It's from a colleague of yours.
Oh.
So you go to a head
That's
injury.
slightly scary, but, yeah.
You go to a head injury in the pre-hospital field, and the GCS is 8 to 12. Are you giving TXA?
No,
Thank you.
probably not.
Thank you.
Thank you.
Thank you, Ari. Thank you so much for answering all those questions as well. Fully loaded with those. So thanks everyone for joining us. So next month's Academic Forum, we've got the date 20th of February. We'll be publicising the topic very shortly. And as you can see, the link for your feedback and certificates are there. And we have got a link to our donate site if you wish to donate. There is a small cost that we're incurring just to keep these forums running. So any IT issues and stuff just needs to be picked up. So we'd really appreciate any small donation. But yeah, please get your feedback and certificate online. And thanks for coming. We'll see you next month.